The time to build is upon us.
With great power comes great responsibility.
You know the greatest danger facing us is ourselves.
Irrational fear, we all know.
Not because they are easy, but because they are hard.
This is the Superhuman Academy podcast.
Well, I'm so glad that we're getting the opportunity to talk again. Our first conversation was already fascinating, and I really want to hear more about the research that you've done. Would you mind just kind of sharing the big picture overview, and then we can dive in where it's most interesting?
Yeah, well, the big picture is that the brain can cause physical symptoms, pain or illness, anywhere in the body, often in multiple locations. It's kind of a third form of illness. You can have organ disease, you can have injury, but you can also have brain-generated symptoms. And these are actually responsible for 40% of the people who come to a doctor's office. So it's tens of millions of people in the United States alone, but very few healthcare professionals have had formal training on how to diagnose or treat it. And a number of colleagues of mine and I have developed very successful treatment methods for this, uncovering issues in people's lives, whether it's stress in the present day or long-term impacts of adversity in childhood or traumas or repressed emotions or personality characteristics that can be stressful. And we can address those successfully for people, and they can make significant progress, often in a surprisingly short period of time, in alleviating their symptoms. And my colleagues and I have been doing this for years, many of us for decades. I've been doing it since 1982. But we had difficulty persuading other physicians and mental health professionals, and even the public for that matter, that this was a real thing, that we could actually do this on a sustained basis. So we went to initially to a group of world-class researchers at the University of Colorado who had a lot of skills in scanning brains, a lot of skills in doing controlled trials. And we approached them and said, look, we want you to do a rigorous test of the ideas that we believe work, that we have seen work in our patients. And let's see where it shakes out. Let's compare it to some control groups so that we're not just looking at placebo effects here, that we're able to tell whether something is a real benefit or not. And they went for it. There's a little more to the story than that, but they did the trial. They were skeptical, to be honest, just as I was when I first began in this field. But the results were shocking even to them, and how good they were.
Can I hear some of like the hard data? You mentioned a 40% number or figure earlier. I'm curious where that came from, and then maybe some of the other numbers and results that came out of all of this.
Yeah, there's a study, I believe the authors are Haller and Kramer in 2015. They did a review article of 3 dozen papers almost from 24 countries, just looking at, how many people who come to a primary care doctor's office have these conditions, where there's no organ disease to explain the pain or illness, there's no structural damage. And depending on the paper, I mean, it had a range to it, but it was somewhere between 30 and 45%. So the figure that I quote is 40%,
Okay.
which was about the average for those studies.
Got it. Okay. And so basically, you've got people coming into the doctor's office. They do tests of some sort. They conclude, all right, there's no physical structural damage anywhere that we can find. There's no disease or virus that we can attribute this to. Therefore, it's just in this ambiguous third category.
Yeah, or there oftentimes the patients are dismissed as it being all in your head. The implicit teaching around this is that there aren't that many of these patients. It's all in their heads. They can't handle their own stress in life. There's nothing you can do for them. You can't diagnose them. The best you can hope for is that they can live with their condition a little better. And it turns out not a single one of those assumptions is true, although those are the ones that are carried around by most healthcare professionals these days, unfortunately. In fact, not only are the assumptions not true, most cases the exact opposite is the truth. You can diagnose this accurately if you know what to look for. You can treat it successfully. One of my patients had been hospitalized at a prestigious university 60 times in 15 years with no diagnosis. They even had a psychiatrist interview her. I might have mentioned this story the last time,
Yeah.
but
Yeah, I remember you mentioning that.
she was cured in less than an hour.
Yeah. Okay, so I definitely wanna ask more about that, but you mentioned there are signs, there are ways that you can determine if somebody fits in this category. What are those ways? How do you do that?
Yeah, first, most important is to make sure that there's no organ disease or structural damage and that the
Okay.
tests are not showing that. And sometimes the tests will show an issue, but it turns out that whatever they found, and this happens a lot in people with chronic back pain, very common to have minor abnormalities that are age related in the spine, even in people in their 30s and 40s and on up from there. But most of the time, we start with a negative diagnostic evaluation, and then I assess people for stress. Our simplest thing is, are you having stress in your life right now? Or was there a major event, a trauma, or a stress that began right around the time your symptoms started? The simplest example I can think of from this is a gentleman, and none of his other doctors found this. He was only having his symptoms when he drove to work.
Mhm.
When he was
Yeah.
driving home from work, he was fine. So, that kinda tells
Right.
you where to look, for this individual's, source, of illness, and sure enough, there was big time
Oh.
stress in his, workplace. So
Okay,
that's
so
that's the first thing.
one key thing is like, okay, is this all the time, or are there certain regularities or patterns and timing of when you feel this pain?
Yeah, that's
Okay.
right. Is there a fluctuation in,
Yeah.
relation to stress? That was the issue with the patient who was hospitalized at the university 60 times. Her symptoms, which was dizziness and vomiting, both fairly extreme, were all connected to interactions, direct or indirect, with her abusive mother, and she never put it together. But,
Mhm.
in talking to her for 30, 40 minutes, it became very clear that that was the trigger for her. Um,
Got it.
so the next thing I look for is, um, what kind of stresses did the individual have when they were children? Did they go through what are called adverse childhood experiences, or ACEs? And this can be anything that you would never want for a child of your own or a child that you care about. Sometimes it's really obvious, physical or sexual abuse, emotional or verbal abuse, a severe substance abuse problem in one of the parents,
Mhm.
sudden death or suicide of a parent. All kinds of terrible things that are strikingly obvious. But it can also be much more subtle. It can be anything that knocks your self-esteem down on a long-term basis. I was speaking with a gentleman just yesterday. He realized he was gay when he was around 13 years old, and he had the belief that if anybody found out, he'd be tossed out of his family. This turned
Mhm.
out not to be true, but for a period of years, he had to be on his guard 24/7, and had this terrible insecurity and feeling of negativity about himself for all those years that nobody knew about, and it was just a huge burden, and it led to triggering of a series of personality traits in him that became very stressful for him as an adult. Even after he successfully came out to his family and they
Mhm.
supported him, by then he had numerous highly stressful personality traits that created an illness that lasted for years and years.
So how do you make the link between the symptoms and an adverse childhood experience? Because I could definitely see, like, everyone's had, you know,
Something.
something in their life, but how do you know if that is connected to the symptoms or if it's just they're unrelated to each other?
Yeah, you don't always know, but usually, and as with experience, you can tell what kinds of issues are significant enough to produce physical illness, and they're usually the issues that are able to produce long-term impacts on a person. That they're not being left in the past. That you can still find issues in the present day that are stressful, that are linked to the past, and the personality traits is a big one. Many people survive their adversity in childhood by becoming, focusing on becoming extremely good
Mm-hmm.
human beings, perfectionists. They're highly self-critical. They also tend not to be assertive. They've learned as kids that they need to kind of fade into the background when it comes to
Sure.
their own needs. They tend not to be very good at self-care. They often are people who are so focused on the needs of everybody else in their world that they fail to put themselves on the list of people they take care of. You ask them, "What do you do for fun?" And they're like, "Hmm,
Eh,
not so much."
yeah.
So personality traits, and then there are more of them. Choosing narcissistic partners is another one.
Mhm.
Some of my patients, one of my patients was on her fifth marriage, and only number five was a good one. Another one of my patients was an actress who had a new boyfriend every 18 months, and they were all bad. For 20 years since adolescence, she had new boyfriends every 18 months, and they were all bad in their own way, but they
Mhm.
were all bad. So choosing those negative partners. So personality traits like that. Second area are triggers. Something in your life today that is highly stressful for you because it is reminiscent or linked to the past, like the patient at the university whose mother was abusive towards her. Mother was still in her life. The mother was in her 70s, patient was 50, and mother was still verbally and emotionally abusive towards her. And those episodes were highly triggering for that patient. But it
So
can be other things as well that are in the present day.
so would it be accurate to say that, and I'm just trying to puzzle this together, that the symptoms that they're experiencing are some sort of, I don't know, built up coping or defense mechanism somehow? I'm trying to piece together, like,
Mhm.
why there would be the physical pain symptoms associated with that, maybe traumatic experience, how that would be helpful or what the brain is trying to do.
Yeah, it's not so much helpful as we have studies now, functional magnetic resonance imaging scans of the brain that show anatomic changes in the brains of people with
Mm,
these issues. So the brain is actually processing signals from the body. We all get signals from the body all the time, but when you
okay.
have one of these conditions, it's being processed in a different way, and pain is the result. It turns out that all pain is kind of manufactured or generated in the brain. When you whack
Mhm.
your thumb with a hammer, it actually isn't the thumb that is painful. The thumb instead is generating a damage signal, and it sends the damage signal up to your brain, and the brain then makes a decision. Um, am I going to create a sensation of pain for you in that location or not? And all pain works that way. Um, the classic example of the opposite is somebody who's wounded in military combat and doesn't feel the pain until they get to a safe location. Or if you sprain your
Right.
ankle while running from a bear, you're not going to feel pain in the ankle until you escape the bear.
Yeah, and your brain is, like, actively suppressing those signals until it's
Yeah,
a time when you could potentially deal with it.
it's receiving the signals, and it's making a decision that you are not going to feel pain in that location until you are safe. But it can
Okay,
do the opposite as well and generate pain or illness in your body, um,
this is
even
a
when there's nothing physically wrong.
little bit of a side tangent, but I have some rudimentary knowledge here, so I wanna test myself here. You said that the pain or the brain is receiving the pain signal, but it's essentially opting not to process it or something like that?
Opting not to give you a
N
pain
Not to
signal, not to give
consciously
you a
make it.
pain response to it. Yeah.
So, my understanding was that it wasn't actually receiving the signal because it would block it. It would send, basically, you've got endogenous opioids that are produced, and it would block the signal from actually traveling up all the way to your brain. Is that not correct?
There are gates along the way that can be affected by the brain, but the easiest way to think about this is um, as the brain making a choice about what kind of sensation you're going to feel in that body location. And we all have physical responses to reactions that our brains are having to the world. If you're in a tense situation, you might feel a knot in your stomach. If you're embarrassed, your face might flush red. Those kinds of things are common human experiences. You might have develop a headache if you've had a long tough day. Um, all of those things are um, the brain causing impacts in the body in response to stresses or to emotions. Those are very common human experiences. In this form of illness that we're talking about, it's just more severe and more long lasting, but it's the same nerve pathways. It's the same kind of phenomenon.
Okay. I don't know if I fully bridged the gap from where I was at with the defense mechanism thing. Is it so, like, let's just talk about the woman who was, experiencing, vomiting when, um, she was I think you said driving nearby. I'm tr we had a
Yeah,
previous
she was.
conversation, and I might be
Yeah,
mixing
she
up
was.
other things that you said.
Yeah, she when she would have her annual visit to go see mom,
Yeah, right, okay.
40 minutes down the road, after 40 minutes of dread about the upcoming visit, her husband would have to pull the car over, and she'd be vomiting all over the road.
So
And
is the brain in that case, is it trying to say, like, "Don't go there, I'm going to, like, make this really unpleasant for you"? Is that a right way of thinking about it, or am I going off the road
yeah,
a little bit with that?
yeah, there are different ways to think about it, and the way I think about it is that it's just a more severe, reaction. I mean, let's say you're going for a job interview and you really wanna get that job, and
Yeah.
you're not sure if you're gonna get that job, and you start getting a knot, in your stomach,
Mhm.
or you're sitting, you're buckling down on the racetrack to run the 100 meters in the Olympics, and your stomach is tightening up with the anticipation of it. This is the same kind of thing that was happening to this woman, who just a much more obviously severe
Mhm.
reaction that she was having than a little knot in your abdomen.
I
Um,
see. So you could just call it like an acute stress response?
yes,
Okay. Okay, and stress can manifest in a lot of different ways for people, and so that's where you get this variety of symptoms?
yeah, it can be anything from headaches to ankle pain, and I've seen them all. The only common denominator is that you can have more than one of these symptoms at the same time. My personal record patient had 27 different symptoms
Oh, wow.
simultaneously. He came to me with a printout from the internet, and he said, I got all of these things, and he had circled them all on this page. But he was completely cured in 30 days.
Okay, so now I have to return to that topic, which is the solution. You said someone was cured in an hour, 30 days. Those are both relatively short timelines when thinking about, like, lifelong health conditions. So, how is that possible? What are you doing that's different?
Yeah, well, I want to back up for 1 minute about the other causes of these
Okay.
conditions before we get to the treatment, and because we left out another long-term impact of childhood adversity, which is repressed emotions. That
Mhm.
people can have tremendous amounts of anger, fear, shame, grief, guilt, um, anger being the most common, um, without recognizing it. And it just anger always manifests in the body if you've got enough of it. But in this
Yeah.
case, people often learned as children that expressing anger was not a good idea, so they repressed it. And by the time they're adults, they're so good at it that they don't even know they're angry. But the physical manifestation of the anger is still there.
Mhm.
So that's it turns out to be an important part of the treatment, is to identify that. And then the last three areas that I investigate when I have a patient in front of me is to make sure that they're not suffering from depression, which can be subtle in many cases. Many people with depression, for example, when you ask them, "Do you feel depressed?" They say, "Well, not really. Stressed, frustrated, exasperated,
Mhm.
desperate to have you fix this physical symptom that I'm coming to see you for, but not so much depressed." But they have other symptoms that are very much connected with depression, and that's how you can make the diagnosis. Similarly, with anxiety, many people have been so anxious for so long that they just don't perceive it anymore. But you can tell that that's what's going on because their symptoms are much less severe or less frequent whenever they are in a safe environment, whatever safe is for them. And then finally, the one of the more obvious ones, but unfortunately, doctors don't ask about it nearly as much as they should, which is trauma. Have you been through a terrifying or horrifying event? Did that event happen right before you became ill? Or was the trauma connected to an event that happened to you right before you became ill? One of a colleague of mine in Arizona told me a story about a woman who'd been from doctor to doctor unsuccessfully trying to find out why she was ill.
Mhm.
And he was the one who found out that right before her illness began, she had been a hostage during the robbery of a store. And for 40 minutes, she was in the grasp of one of the robbers with a pistol pointed at her neck.
Wow.
And this happened, right before her illness began. But, unfortunately, physicians are not trained to look for this sort of thing. So this then leads into your other question, which is about, well, how do we fix this? What do we do for this? And um, once you've identified what the stress is, the plan of treatment is usually fairly straightforward. The challenging ones, the most challenging ones, are how do you help somebody who has been through adversity as a child and they're now an adult? Um, what do you do for that person? And there are a number of things. First is to help people recognize accurately how much they went through, because typically, because none of us has a parallel life to compare ourselves with, when a
Right.
person looks back at their own life, um, are not necessarily fully perceiving accurately how much they overcame. And what I found works best for that is to have a person imagine themselves a butterfly on the wall of their childhood home. We may have talked about this previously, but
Mhm.
and imagine a child of their own or a child they care about um, living through exactly the same experiences that the patient did. While the patient is just, they're on the wall, they can't do anything about it. They just have to watch, say, just for a week or so. And what is that going to be like for them? That oftentimes gives people a dramatically different and more accurate concept of how much they had to overcome. And from there, obviously not an easy thought experiment to do. But
Yeah.
from there, I try to have people realize, you did a remarkable thing coming through this. You had to have courage and heroic perseverance to make it through this kind of experience. My very first patient was sexually assaulted by her own father hundreds of times between the ages of 4 and 12. Absolutely horrific. To this day, the worst story of sexual abuse I've ever heard. But her reaction to that was to feel um, like a worthless piece of crap well into her adult years,
Mhm.
and helping her flip that into realizing, she got thrown into this toxic environment through no fault of her own and deserves enormous credit for having survived it. And if people can give themselves that credit, that's a huge part of their treatment. It completely flips their self-image. It has ripple effects in many other areas of their lives, and it brings the stress level way down, which then brings the symptoms way down. That patient, the one who was sexually assaulted, she was treated by the psychiatrist who became my mentor, and was completely relieved of her very severe symptoms in less than 3 months.
So would you call that acceptance of your own resilience or something like that? Would that be a fair label?
Yeah, I take it one level higher and
Okay.
say acceptance of your own heroism,
Okay.
because I want people to think of themselves in those terms, because, what is a hero in our society? It's somebody who's overcome a difficult physical or mental challenge for a good cause. my childhood stress survivors have usually done exactly that.
Yeah, I see. Okay, so that by itself can make a dramatic difference. Are there steps beyond that or alternative paths to take, or is that the key thing?
Well, it's definitely fundamental, but there are a lot of other things. So many of my patients grew up so focused on the issues in their families that they never really took opportunities to just be a kid, to just
Mhm.
play.
Yeah.
And it turns out when children are playing, they are learning self-care skills. And if you grow up without that, then as adults, the idea of taking time for your own joy becomes a foreign concept. And
Mhm.
my patients in this situation, they are living lives as if they're on a treadmill that they never get off.
Yeah.
They are taking care of everybody else in their world. And you ask them, what do you do for fun? And they have difficulty coming up with anything. And if they ever, think about doing something for fun or actually do something, they start feeling guilty right away because it just
Yeah.
doesn't feel right to them. So I have to try to help them learn that, this is something that they deserve, because all they're doing is putting themselves on the list of people they take care of. And it turns out that being able to take time for your own joy is an essential human skill. If you
Mhm.
don't have it, um, sooner or later your body is going to protest. One of my patients is a good example. She was um, in her early 30s, and I met her for the first time early in the morning in the emergency room where she had been, all night for sudden severe abdominal pain. All the tests were negative, and it turned out she had one of these lifestyles that was, focused on everybody else. She worked full time, husband worked full time. She had been an athlete as a girl. So in her spare time, she was coaching her daughters in her sport. She was coaching other people's kids in her sport. She was on the athletic club board of directors. She was driving kids to out of state competitions, just never stopped. You asked her what she did for fun. She had to think about it for a while and said, "Well,
Mhm.
sometimes I go out to the movies, maybe every other month with my husband. Really not too much there." Well, it
Yeah.
turned out that as a girl, she had been a very high level performer in her sport. But to do that, she had to practice before school, after school, and on weekends from the age of 4 to the age of 18. She never really got to be a kid. Her dad even apologized to her in high school for having pushed her too hard. So, even though there wasn't really an abusive situation going on or a toxic or dysfunctional environment, it ended up having the same effect that she never learned those self-indulgence skills.
Yeah. I can relate to this. I have noticed in myself recently when I just try to sit down and read a fiction book purely for pleasure, I've noticed that little feeling of guilt, which is strange for me. I'm actually not typically like that. I've noticed it cropping up more recently, and it's got given me pause to like think about where that's coming from. But I've seen it a lot with people I've coached. My work is in has been in learning and memory coaching, and so a lot of the adults that I work with, they don't believe that they're a good learner. They have a lot of these beliefs that they're terrible at learning, and it comes from a lot of the experiences they had in school and things people said or grades they got or what have you. But a very, very common thing I've seen is kind of what you described. The label that I hear is perfectionism. I hear that label a lot, and the more I've gotten to wrestle with perfectionism in myself and in others, the more I realize that it's anything but like it's not. I don't know. A lot of people wear it with a little bit of a bad badge of honor, a badge of pride, and it's very counterproductive. Because, like you said, you never give yourself a break, and if you never give yourself a break, if you never give yourself the opportunity to rest and to play and to enjoy life, life is pretty miserable, and painful, and they have to have that outlet and the what would you say, the mercy on yourself? I don't know, maybe that'd be the right term, the mercy, the
Yeah, I would prefer kindness,
Kindness? Yeah.
to, treat yourself as kindly as you do everybody else. To me, perfectionism is never being, satisfied, never being able to, um, give yourself credit or, um, feel like you've, ever done anything well enough. And, if you're on that treadmill, you know, and if you're on that treadmill for whatever it is, 10 or 20 years, when you look back, what are you looking back on? You're looking back on a life of accomplishments that were never good enough.
Yeah.
And that's, um, you know, stressful enough to cause physical illness in many people. Let's put it that way.
Yeah. And I think about my son is 2.5 right now, the time of this recording. And if you asked me, like, do you want your son to never play? Like, what on earth? Of course I want my son to play. 2.5, I want him to play almost all the time.
Mhm. Yeah, and that's when people learn self-care skills. That's
Right.
when they learn that it's okay. Um, that's when they learn, what is needed, for them to feel good about themselves and to have a good time, but so many of my patients never got that opportunity, and they have to learn it as adults, and they can. That
Yeah.
woman in the emergency room with the abdominal pain, um, she was fortunate to have a very supportive, husband, and my prescription for her was to take an afternoon a week, get out of the house, and just do something that had no purpose but her own joy, because that's how you learn self-care skills. You learn them the same way your toddler is learning it, just by doing it. Your toddler, he's going to do something that he thinks is fun, and as soon as it stops being fun, he's going to move on to something else.
Yeah.
If he's doing finger painting, he's not going to care about the number of pictures per hour he's producing. He's not going to care about the quality of the work. He's not going to care whether you see it or not. He just knows he's having fun. Um, and my patient in the ER, she needed that, and it's not easy to learn. It takes time. Usually, my patients need months of trial and error to find something that works for them. What she did was to go for walks in a park, which wasn't enough. Her pain continued at a much lower level. Obviously, she wasn't in the emergency room anymore, but it was still there. And then, but while she was walking in the park, she was thinking, and eventually she hit on the idea of taking piano lessons. I tell this story a lot. I don't know if I'm repeating myself, but she had never done anything musical before, but she absolutely loved it. And once she started doing that, pain went away.
Wow. I was thinking about this conversation we were gonna have, like, this morning as I was brushing my teeth and things like that, and one thing that came to mind for me was, I've known about the placebo effect for a long time. I don't know when I heard it first, but the way it was presented to me was that it was kind of presented as, like, this inconvenience that you have to deal with in drug trials and things like that. You gotta factor for the placebo effect. Sometimes, people will experience relief from their symptoms or legitimate healing or improvement taking a sugar pill because they believe it's gonna help them, and so you gotta factor for that to see if things are actually helping or not, and that was all I thought about it. But then in recent years, as I've thought about that, I'm like, "Wait a minute, you're telling me that there's a very consistent phenomenon of people experiencing legitimate, real healing in their bodies and relief from symptoms purely because they believe that they're taking something that's going to help them. And it's happening sometimes with very serious conditions and diseases and issues. It's like, shouldn't we be focused on that? Like, your brain is able to heal your body from legitimate conditions just by shifting the way that it thinks. Like, that doesn't seem like, I mean, it is a problem with conducting research sometimes, but that also seems like, wow, that's amazing. Like,
It
what does it
is
tell us
it
about how
is
our brain
amazing,
works?
it is due to a physical change in the brain, so it's real. This is the placebo effect is not imaginary. It's a genuine and neuroanatomic phenomenon. The good news about this whole line of healthcare that I've been talking about is that we can go well beyond the placebo effect. Um, uh, just to get into numbers just a little bit, I mean, the there's a number in research, and this goes back to the research study I was talking about before that was done in Boulder, Colorado. There's a number called the effect size, which is basically the magnitude of the benefit of your treatment. And
Yeah.
the numbers are usually somewhere between 0 and 1. And if you have 0 effect size, that means exactly what it sounds like is you haven't done the patient any good at all.
Mhm.
If you get to 0.2, that's a small one. 0.5 is considered medium, and 0.8 is considered large. If you can achieve a 0.8 effect size, you are really onto something.
Mhm.
This whole line of treatment that I've been talking about in the Boulder study achieved an effect size of 1.5. It was off the charts. The researchers were shocked. That study had the biggest effect size of any study of talk therapy in chronic pain ever. The patients that they used had been in chronic back pain for an average of a decade. All they got was 2 sessions a week for 4 weeks of pain relief psychology, which is basically everything that I've been talking about here
Yeah.
with respect to treatment. And they just got 8 sessions, 1 hour each. Their pain scores dropped 75% in 1 month. This is
Wow.
after 10 years of being in pain. It was just extraordinary. It got, Washington Post wrote it up, CBS News. It was published in the Journal of the American Medical Association, Psychiatry Journal in September of 21. It unlocked all kinds of research dollars to do even more studies, which are currently underway. Several have been finished. Halifax, Harvard, Detroit, UCLA are all now confirming the same thing. We haven't talked about all the different kinds of treatment, but we've talked
Yeah.
about some of the major ones and that are used. And they it to me, it's like discovering insulin for the first time. The It's that level of benefit from this. The problem is that only maybe 1 in 5,000 people who could benefit from this are currently receiving it. So my
Mhm.
nonprofit, symptomatic.me, is trying to educate healthcare professionals and the public about the benefits of this and how extraordinary they are.
Yeah, and that's what I was thinking this morning as I was brushing my teeth. It's like what you're doing is taking the underlying mechanisms of the what we call the placebo effect, but it's really like the brain's ability to heal and change the body. That's how I think of it anyway. I'd love to
Yeah,
hear how
no,
you
it's
say it.
taking that and magnifying it
Yeah,
because, the placebo effect is gonna give you an effect size of maybe point 0.1, something like
sure.
that. And in fact, the effect sizes are typically compared to the placebo effect. So it's, how
Right.
much beyond the placebo effect did you get?
Mhm.
And we got 4 or 5 times as much as the more standard cognitive behavioral therapy, for example, or placebo injection was used in the Boulder back pain study. They took a big syringe and injected into
Wow.
people's spines, and that gives you a whopping placebo effect.
Right.
And the pain relief psychology just knocked that out of the park. In the Harvard study, they compared it with mindfulness stress reduction, and they got 25% of their patients to be pain-free with mindfulness-based stress reduction, which is, pretty good.
Yeah, very good.
But the pain relief psychology, they got 64%. As one of my colleagues put it, if it was a football game, the score would be 64 to 25.
That's a pretty good score. Alright, so I'm very familiar with lots of different psychological or psychotherapeutic tools and practices and methods. Um, and so, yeah, I am curious to hear more about how it differs. So you shared one specific method of people putting themselves as like a butterfly on the wall and viewing their own child or a child that they care about going through the same experiences. So that's one method. What are some of the other tools in the toolbox?
Yeah, actually, the butterfly on the wall is what I use to help people connect with their emotions, and it's really
Okay.
powerful technique. They didn't even use that in the Boulder study.
Okay.
They only had the 8 sessions. So what they did there was they explained to people that the pain that they were experiencing, and these were all back pain patients, was
Mhm.
not they previously checked them all out and made sure that there was no structural cause for the patient's back pain. And so they said, you don't have to worry about damage to your back. You don't have to have fear connected to that. Instead, we want you to just, yes, you can be aware of the pain. You can notice the pain. You can kind of track it the way you might track an automobile driving by on the road. But we want you to shift your attention to your brain and what's going on there that might be stressful for you, and start thinking about what might be the actual cause of this pain. And just, the biggest single thing they did was shift people's attention from where it naturally gravitates, which is their
Mhm.
back, to the brain, and trying to figure out what's going on there. And, being a little kinder to themselves about what finding the stress and coping with the stress that's happening in their brain and causing these neuroanatomic changes. That's huge for people. Just to hear that your back is okay, you're not going to be damaging it. You don't have to worry about progressive lifelong disability. You have to instead think about what's happening in your brain and your life, and see if you can make some changes there that might alleviate some of the stresses that are going on. And very simple
Mm.
approach, but it gets the patient's full cognitive capacity focused on where it belongs,
Yeah.
on the real issue, and that alone, as simple as it is tremendously powerful for people. The digging into the emotions and the long-term impact of childhood stress um, is sort of next level, let's put it that way. That's a version of pain relief psychology that we call emotional awareness and expression therapy. It's what I use typically
Mhm.
because as a specialist, I tend to get the more severely afflicted people. And
Mm.
I find that connecting people with their emotions, and also making sure that I've identified any triggers that they have in their life, um, those are often what are needed for more severely afflicted people to make a recovery.
So, one question I had related to that, you have in the Boulder study, you said these people on average had been experiencing pain for a decade, 10 years, right? So I could imagine if somebody in that situation is told what you just said, there could be some defensiveness of, like, not wanting to accept that because it's like, "Well, man, you mean I could have just gotten rid of this 10 years ago if I just, thought different thoughts?" Do you have that friction sometimes with people not wanting
That
to?
friction, not so much, but
Okay.
people naturally find it difficult to believe just
Yeah.
how ill you can get from this process. I was the same way. That very first patient of mine, she was averaging one bowel movement per month, despite taking 4 different laxatives at double the usual doses every day. And I'm going, this can't be from the brain. This has to be, an underlying neuromuscular disease of the large intestine. We tested for that. She didn't have it. And when this patient was cured by the psychiatrist with 10 sessions of counseling, just talk therapy, special, uh,
Mhm.
highly insightful talk therapy, but just talking to her to make a condition like that go away, I was blown away. I was in my 8th year of medical training. I had done very well. I got an award in medical school. I got high scores on the board examinations. The last thing I expected was to encounter this patient that I had no clue what to do for. And I was very skeptical until I, had to confront it because the patient was well. And since then, I've seen patient after patient with very severe levels of disease. One of my patients had a completely paralyzed stomach. A 24-year-old man, we put the radionuclide material in his stomach and scanned him for 2 hours. The stuff just sat there, uh, did not move at all. It was supposed to be, out of his stomach in an hour and a half.
Mhm.
2 hours later, they called me from the scanning room and said, "This stuff is still sitting there. How much longer do you want us to scan him?" And I said, "I've got my answer. You can stop now." Another
Wow.
patient, I was a 17-year-old girl. I was asked to see her on her 70th day in the hospital. I may have told this story before too, but she was getting morphine around the clock. Um, you know, uh, 10 milligrams an hour. 5 or 10 milligrams would be enough to alleviate the uh, pain of a fractured leg. And she was
Yeah.
getting this, 10 milligrams every hour for unexplained abdominal pain. The level of severity. Another guy, total body itching of his skin for 3 years. And I know that all of these patients, it was 100% stress related because every one of them was successfully treated. Even the girl on the morphine around the clock, she was out of the hospital in a week, and she was completely off of all opioids 30 days after we met.
I'd like to talk to you a little bit offline about some specific cases that I can think of right now, I think, but for privacy, I'll leave those
Yeah,
for later, but
yeah. Most people know somebody who's got
yeah,
this.
yeah, I think that's definitely possible. Alright, I do wanna dig back into the Boulder study you said. You gave one example, I think it was, like, here's the first session, what was talked about. Are you able to disclose, like, some of the other things that were done?
That was the main one was teaching people that when that back pain flares up, to try not to panic, try not to, become hopeless and catastrophizing, just to say, okay, my body is actually my friend. Um, my brain is trying to communicate to me via these terrible symptoms that there is a source of distress in my life, past or present, that
Mhm,
wants to be addressed, and let me shift my attention from my back. And it takes time to learn this. That's why it stretched out over a month, to, after 10 years of focusing on your back every day,
mhm,
shift your attention to your brain, and from there to what's going on in your life. Um, Having the feeling that, as bad as this pain is, it's just a signal that my brain is in distress and that wants some help with something, and that it's no more than a form of communication. And that brings the whole, panic and distress level way down,
mhm,
and enables people to more calmly start looking for the underlying reasons. And Granted, this is, very straightforward, simple technique. Part of it also is assuring people that, we're not just doing this to help you live with your pain. We are doing this to get rid of your pain.
yeah,
Um, and that's a huge shift. Most psychotherapy for chronic pain uh, is about helping people live with it better, and
right.
that we're going way beyond that.
Yeah, I was thinking about, like, I believe it's ACT, for example. A lot of
Right.
that is, learning how to live with things more effective and I think like, often people do experience some alleviation of pain from that, but it's
They
definitely
do. They
different.
got the small effect
Right,
size.
right, yeah, but it's definitely a different way of thinking about it.
Yeah, the
I
A in ACT stands for acceptance.
acceptance, yeah.
We don't want people to accept it.
Right, yeah, that's what I was saying, it's kinda the opposite.
Do not put up with this.
Yeah, I appreciate that, and I'm guessing you've probably had a lot of people who, like, they've not gotten really a diagnosis and have been referred to physical therapy. Is that pretty frequent too, where they're doing routines of stretching and rolling and
Mhm.
this, that, and the
Yeah.
other.
Sadly, not just I've got the sunrise in my face here, you may have
That's
noticed.
okay.
But
I've got a bunch of
sadly,
snow
it's not
reflection
just
here.
yeah,
Yeah.
just physical therapy. It's, spine surgery.
Oh,
There was a paper, I believe the author's last name was Deyo, Deyo, that showed that this Medicare statistics are that spine surgery rates were going up. You know, people chronic pain is going up, and consequently, injections of, various kinds, nerve ablations where they cauterize the nerves they think are responsible, various kinds of, spine surgery interventions. The spine surgery success rate, is on the order of 25%.
man. I
There's
can't
also a s
imagine getting spine surgery and then having the symptoms persist. That is just
or get
or
worse,
get worse.
or
Oh,
have a complication. Yeah,
that's awful.
yeah, it is. The interesting story about one of my colleagues who's he's a spine surgeon, and he was familiar with some of these psychosocial stresses from his own personal life. And he was also familiar with the terrible success rates of surgery for pain. It's different if you've got nerve damage. If you've lost your reflexes or your muscles are weak, then that's a completely different ballpark. But what he decided to do was send his patients to a psychologist who was familiar with some of these ideas that we're talking about, and to do it before the surgery. And he called it
Yeah.
prehab.
Yeah.
Very clever name. And his thinking was he's still going to do the surgery, but that the results might be better if they got some psychotherapy beforehand. And you can probably guess what happened. The
Lots of
psychologist was
cancellations.
curing his patients right and left. And so he was spending as a result of this, and he said some of the patients, if you showed the x-ray to 10 spine surgeons, all 10 of them would say that patient needs surgery. And even those patients, in many cases, were alleviated, had their pain alleviated by the psychologist. So suddenly, he's not doing nearly as many spine surgery cases, and he gets a call from the hospital and says, "Hey, we got this expensive operating room that's all set up for spine surgery, and you're not using it. What's going on? We're losing money over this thing." And it was a revelation to him. He subsequently wrote a book about helping people decide if they need spine surgery or not.
Oh,
Uh,
what was that book
Um,
or the author?
yeah, Hanscom, Hanscom. I believe the title was "Do You Really Need Spine Surgery?" But
Okay.
along
Well,
those
if
lines.
there's even one listener out there for whom that question is relevant, I'm sure they will really appreciate
All right.
that.
Well, I gotta
Go
push
ahead and
my
get
own
that
book
out
too
get it
my
out
own
there.
book too, which is called "They Can't Find Anything Wrong," which is about, all the other symptoms.
Yeah. Yeah.
But
Okay.
one last thing about the
Yeah.
spine
Go
surgery. There
ahead.
was a great study from, about 30 years ago now, that looked at adverse childhood experiences and looked at spine surgery outcomes, just to see, they weren't focused so much on what kind of spine surgery, just um, whether the surgery was successful or not. And it turned out the more adverse childhood experiences you had been through, the less likely your spine surgery was to be successful. So people they divided the adversities into 5 different categories, and the more of those categories you had, the less likely your spine surgery was to be successful. And it was dramatic. If you had no childhood adversity, the spine surgery success rate was something like 95%. If you had 3, 4, or 5 out of the 5 categories, and you had that in your life, the spine surgery success rate was 15%.
I want anyone listening to this conversation to whether you have spine surgery on your schedule or not, to rewind and re-listen to that, because I think, at least for me, like, that gives me such pause and also a lot of hope with, if I'm experiencing pain, which I have, everyone does, to think about this I mean, that's spine surgery, but that's everything, right? That's like
Oh,
that could
yes.
be
It's
any
Yeah, the symptoms are, I should have given you the list, but migraines, dizziness, tinnitus, visual disturbances, burning mouth, temporomandibular joints, stiffness and pain, pseudo seizures, difficulty swallowing, and that's just the head and neck. Long COVID in many cases, chronic fatigue in many cases, any kind of spine pain, joint pain, irritable bowel, fibromyalgia, the pelvic pain, genital pain, bladder spasms, certain kinds of rashes. The list is virtually endless of things that can result from this.
from your perspective in your professional experience, is there other than like an acute emergency situation, if somebody has ongoing pain, is there any reason not to consider this before considering other things? This seems like the first step.
Yeah, I mean, considering all these ideas should be part of a complete evaluation. That's all we are advocating for, is to just include this. Now, there are certain people where you really don't need to do this. As you pointed out, something of an acute nature or a physical injury. If you do a physical examination and you find a definite abnormality on your exam that's in the area where the symptoms are happening, you can probably bypass this whole area. But
Mhm.
if the physical examination is negative and the symptoms have been going on for a while, the longer the symptoms have been going on, the more likely it is to be related to stress of one sort or
Yeah.
another. Especially if it's gone on for years or decades and nobody's found an explanation for it.
Yeah, because this seems to me like assuming that the clock isn't ticking on something else, but if you haven't gotten any diagnosis and you've had the examinations, this seems like a no harm, probably
Yeah.
no negative side effect approach that could change everything.
On symptomatic.me, we have a 12-question quiz for people to self-assess themselves, and each question comes with a line or two of explanation of what the question means. And it's
Mhm.
designed in a way that the more questions to which you answer yes, the more likely it is that you have a stress-related condition. And takes less than 3 minutes.
Yeah, I did take that, by the way, already. I appreciated it. I thought it was very clear and easy to go through. If somebody, let's say they take that quiz or they're listening to this and they're thinking this might be affecting me or someone I care about, is there a way that people can sign up for a consultation or something? Like, what would be the next steps for them?
Yeah, I would definitely take that quiz, and,
Okay.
if you've got a lot of yes answers, there are abundant resources, on the website. We've got, self-treatment courses, courses for professionals, but they are jargon-free, so anybody
Mm,
can go through those. We've got
yeah.
evidence-based, books that people can read, that we recommend, on the website. We have an annual conference, that we just first one post-COVID that was live, was last September. We're doing another one, in Boulder, Colorado, this coming September from the
Mhm.
28th to the 30th. We've got, recordings from all of our conferences, lots and lots of resources, and a practitioner directory. If the resources on the website itself are not enough, you can find a practitioner that geographically near you, or one that may be remote but that is able to do things via the internet, and
Mhm.
evaluate you in that way. So lots and lots of resources to help people with this.
Okay, and last question for you. I'm legitimately interested in potentially getting certified in this, if that's even a possibility. What would that pathway look like?
We have a committee that's actually working on that for people that are um, not licensed healthcare
Right.
professionals, and that's in process. But we are hoping to have a set of criteria that will
Mhm.
enable people to get not necessarily certified, but trained, and able to help others with this. And we will list those people in a directory. We are expecting that they will be more affordable than somebody who's
Mhm.
a psychologist or a physician, for example. But we hope that by the time they've gone through that our training process, they will be well qualified to help others who are going through this. So that's something that's in process. We have a membership program. If people sign up and pay a nominal monthly or annual fee, they can be on our mailing list, and they can participate in monthly question and answer sessions via Zoom, and they will definitely be letting everybody on that list know when the coaches program is ready to roll.
Yeah, if you need another guinea pig for something like that, I wanna be on that list.
Yeah, by all means, come to the website, sign up as a member, and you'll be able to participate in everything we do, and you get significant discounts on our courses and conferences. We're trying to build a community that will also be, in truth, working for social justice in this area. I mean, there is absolutely no reason why somebody with back pain, for example, um, caused by nerve damage, should get vastly better care than somebody with exactly the same back pain from a stress-related cause. I mean, it's the same back pain.
Yeah.
They should both be getting the highest quality care, and they are not, and not anywhere close to it. And for me, that's a social injustice that needs to be corrected.
All right. Well, I think that's a great note to end on. I really appreciate your time. This has been enlightening to me. I'm going to do more research and I'm going to reach out to you after this about some other cases. But I really appreciate the time. Thank you so much. And for all the work that you've done.
Thank you so much, Colin. Been a pleasure to speak with you.
All right. Bye.
The Superhuman Academy podcast is hosted by Collin Jewett and designed and edited by Army Cinco, with original music by Joshua Schunig and voiceovers by Corey Page Schunig. That's me. You can find past episodes and resources, as well as access to the ever-growing Superhuman Academy community at superhumanacademy.com. If you like the show, don't forget to subscribe and leave us a review on your podcast platform of choice.